Welcome or welcome back to the second session of the Brain Lab in the Spotlight, in the series of Spotlight on Rehabilitation, hosted by our school, the School of Physical and Occupational Therapy at McGill. Before I pass on the word to Marie-Hélène and Marie-Hélène to her guests, I would like to read the land acknowledgement. McGill University is situated on the traditional territory of the Kanien'kehá:ka, a place which has long served as a site of meeting and exchange amongst nations. We recognize and respect the Kanien'kehá:ka as the traditional custodians of the lands and waters on which we meet today. Marie-Hélène, over to you. And before I completely turn off my mic, I would like to let you know that last week's presentation will be hosted, the recording of the presentation will be hosted on our school's website, as will the one from today and then the one from next week, November 13th, the last in the series of 3. So enjoy the presentations. Marie-Hélène.
Thank you, Eva. Bonjour à toutes et à tous. Merci de vous être de nouveau joints à nous en si grand nombre aujourd'hui dans le cadre de ce deuxième webinaire d'une série de 3 sur le thème de la COVID. Avant de débuter les présentations, je vais vous faire un aperçu des recherches menées dans mon laboratoire. Thank you for joining us in such large numbers today again for this second webinar in our 3-part COVID series. Before we begin the presentation, I will give you an overview of the research being carried out in my lab. In my lab, our research interests can be categorized in 3 areas. First, neuroimaging, where we quantify brain networks and identify biomarkers of motor and cognitive function using the newest advances in neuroimaging, neurophysiological techniques, and signal processing. The second area is neurorehabilitation, where we are doing so in the context of aging, stroke, and long COVID. Our ultimate goal is to design therapeutic interventions specific to each individual based on brain biomarkers. We specifically focused on using brain stimulation and neurofeedback approach. And third, most recently, our team has been interested in the impact of COVID on the brain, the delivery of rehabilitation services, and the well-being of individuals impacted by long COVID. Nous sommes ravis d'accueillir Nathanael Rafinejad, étudiant en travailleur social qui a rejoint le Brain Lab en début de l'année 2024. Il nous partagera ses réflexions sur les défis de vivre avec la COVID longue en abordant ce sujet à la fois sous un angle personnel et du point de vue du travail social. Nous avons également le plaisir d'accueillir le Dr Kieran Quinn, médecin interniste de l'Université de Toronto et chercheur invité, qui se consacre activement à la reconnaissance et la prise en charge des personnes vivant avec la COVID longue. We are delighted to welcome Nathanael Rafinejad, a social work student who joined the Brain Lab in early 2024. Since the beginning of their studies at McGill, they have been advocating for accessibility for themselves and other disabled students. Today, they will share their thoughts on the challenges of living with long COVID, approaching the subject from both a personal and a social work perspective. We are thrilled to welcome Dr. Kieran Quinn, a general internist and palliative care clinician scientist at Sinai Health in the Department of Medicine and Institute of Health Policy, Management and Evaluation at the University of Toronto. His research focuses on using advanced analytic methods to enhance access to high-quality end-of-life care for people with non-cancer illness and to improve the recognition of care of people with post-COVID-19 condition. Dr. Quinn is currently co-chair for the development of clinical practice guidelines for the treatment of post-COVID-19 condition in Canada, topic that he will discuss with us today. Nous répondrons à vos questions en français et en anglais à la fin des présentations. Nous serions ravis de vous entendre sur le contenu présenté dans le cadre de ce webinaire. Nous sommes aussi toujours à la recherche de collaboration, alors n'hésitez pas à nous contacter en utilisant le lien BrainLab sur la diapo devant vous. We are always open to collaborate and welcome feedback, so feel free to contact us through the BrainLab link in the slide here. We would love to hear from you. We will answer questions in French and English at the end of the presentation. Sans plus attendre, je laisse la parole à Nathanael Rafinejad.
Thank you so much. I'm just going to share my screen real quick. All right, let me know if you can see my slide. All right,
Perfect.
All right, so thank you, everyone. I'm very excited to be here today and to have the health to be here today. I'm going to be talking about long COVID from a social work lens, both my personal experience, and I'm also going to mention the research project that I'm doing with Marie-Hélène in the lab. So the title in progress is Living with Long COVID from a social work perspective. I am doing this with the supervision of Marie-Hélène Boudrias, but also Aline Bogossian, a professor of social work at the University of Montreal. I'm just going to go quickly over this because I have a lot of things to say. So in terms of the research design, in terms of eligibility, we did not want to limit the eligibility to people who have a long COVID diagnosis, because the purpose of our sampling is to have as much diversity as possible. So when we're thinking about diversity, we're thinking about the nature of symptoms that people experience, the severity of those symptoms, but also the social demographic factors, so geographic location, race, ethnicity, gender, etc. So far, we have completed 12 interviews. Each interview is about an hour and a half. Sometimes we fraction that over several days to respect people's ability to participate in such a demanding way. And we're following the methodology of interpretative phenomenological analysis. So what does this mean is that we're going to do a very close reading of each interview transcript so we can understand how people make sense of having long COVID. So it's really about exploring in depth how people create meaning to the events that are happening to themselves. And our goal is to both capture common themes across participants, but also individual differences that may be influenced by the socio-demographic factors, symptoms, etc. What we hope to do is to formulate recommendations for an illness-informed social work practice, and also highlight the need for future research in that domain. Some of the limitations that I've faced so far is in the sampling. Our sample is very biased towards dominant groups, so white, middle class, cisgender, and heterosexual. We've recruited most people via Facebook support groups and long COVID clinics, which are environments, that people need a certain level of privilege to access. A lot of people just don't have access to this information and to this level of care. What has solidified my belief that a lot of people, especially in BIPOC and LGBTQ communities, are disproportionately affected beyond the available data that suggested, is that we did recruit one participant through a community setting. And this participant said that she joined the study because it was proof to her that long COVID was real and truly existed. And that if there's a study about it, then it's really happening. And it's not something she can just brush off. And to be clear, this is a participant who has had to stop working because of long COVID. So it's not like the impact of long COVID was minimal on her life. It was a very strong impact, but because of her environment, she did not have, this validation that long COVID was a thing that was happening to her. So now I'm going to be talking a bit more about my own personal account of having long COVID, because I am on medical leave, so I have not had the ability to really analyze and really start, organizing results in any meaningful way. But I will be, mentioning handpicked quotes from the interviews as I go along. So what does long COVID look like for me? I got it in January 2022. It was my only COVID infection. I was 26-year-old. I was not otherwise disabled, pretty average health. And I was diagnosed in June 2022 with long COVID. So for me, that means a lot of dysautonomia, so a lot of tachycardia, orthostatic hypotension with syncopes, which means I faint a lot. I have IBS, brain fog, chronic fatigue with post-exertional malaise, which I will be referring to as PEM from now on. I'm lucky that I have medication that helps a lot with the dysautonomia and with the brain fog, but I still need mobility aids on a daily basis. I have a wheelchair, I have a rollator, I have a platform crutch, and I also need to use adapted transport. I also have random attacks that incapacitate me at random, and those are unexplained at the moment. I'm the kind of patient who gets worse every time I have a PEM, and I've been having a lot of PEMs. So unfortunately, my baseline has been degrading. And one of my main challenge is how to communicate risk about PEMs with my peers, but also with medical and social providers. So I've been using a fatigue scale, not just as a management tool for me, but also as a communication tool. So I'm showing it to you because I think it's important to have some representation of more severe, like, how severe long COVID can be. And that's something I face a lot in medical settings, is this kind of surprise that I can be that bad with long COVID. So I just want to share, so I've kind of like described it both in terms of fatigue level, but also like this is the stages of my PEM. So when a PM is triggered, I will go through different phases, and each phase is going to last several days. So I just want to share that like the worst of the worst, I cannot move at all. I can move my fingers, I can move my toes, I cannot move my limbs, I cannot chew food, I can barely speak. So I just want to like share this because it's going to, inform a lot of the stories I'm going to be telling from now on. So one of the cycles I encounter is that I will share the extent of my symptoms, I will share documentation, I will share advice, and I face a lot of minimization, a lot of people ignoring the risk. So a lot of preventable incidents occur, trigger a PEM. It takes me weeks to get better. I get back to worse baseline, and now I have even more precautions to take and to communicate. It kind of like snowballs every time. So one of the things I've noticed is that reality tends to be in the eye of the provider, which is to say that a lot of people, and that's normal, very important to me that people understand I'm talking about systemic issues here, not about individual biases so much. But it is just a fact that I've noticed that people are limited by their own beliefs and institutional policies. So I just want to mention two stories that happened to me in recent times. So in August, I had an attack while being downtown at a doctor's appointment, and I had to get back home. Unfortunately, the adapted transport sent me a bus, which I didn't know was a thing. And the bus made me worse because of the lack of suspension in the bus, and movement is very, very bad for me if I'm in a PEM. Unfortunately, the adapted transport left me on the sidewalk without any help. And when I said, well, could you send another car? They said, no, you should have known that you couldn't handle the bus. And anyway, we need a medical letter to prove that you can't handle the bus. So even the reality that I was unable to move was not enough to convince them. I still needed that medical approval. What happens that I had to call 911. 911 refused to get me home. I had to go to the hospital. And at the hospital, I encountered another barrier, which was the triage nurse saying, well, I don't believe that you can't sit. And anyway, we don't have stretchers. So if you can't sit like everyone else, I'm going to call security. So I'm going to, pass you the details, but this resulted in a very difficult way for me to get home. I was very lucky. A taxi driver carried me up the stairs, very kind of him. But it did result in a very violent PEM that I still haven't fully recovered from. Last month, I also had a hospitalization, and I shared all the information with my medical team. I talked to internal medicine, I talked to my surgeon, I talked to the nurses, I made sure that they knew what to do, what not to do. I explained to them that mobilization does not work and will make me worse. Unfortunately, as soon as I woke up from anesthesia, several incidents happened that made me worse. And what I encountered a lot was this idea that, like, I was trying to communicate that I was being harmed by the actions, but they kept saying, oh, you're just uncomfortable, we know better. So this idea, like, I couldn't have my own expertise on my own body and what was happening to me. I also had an incident where I was made to sit up, manhandled into sitting up because I was not able to, without my heart medication. And what the nurse kept repeating was, if I don't mobilize you, I will get in trouble. It's really that fear of punishment. It's policy to mobilize people after a surgery. So if I don't mobilize you, I won't get in trouble. No matter if your chat says not to mobilize you, I am scared of not doing it. And what I, again, heard a lot is the idea of like, oh, I didn't know long COVID could be that bad. When we saw long COVID on your chat, we didn't take it seriously. That's also something that a lot of participants have expressed. I had a participant who said that when she was at the hospital and her testing came back negative, the doctor said, well, while you're still in the wheelchair, you don't need it anymore. As if the testing creates the reality that she needs the wheelchair and not the fact that she needs the wheelchair in the first place. I also tie it to the fact that there is a glorification of overwork. So rest is often perceived as a resistance to treatment and not a valuable treatment in itself. That's how we see a lot of graded exercise therapy and stimulants being forced on people who present with chronic fatigue despite the risk of harm. And there's this idea that bed rest is like a luxury and not a very harrowing and claustrophobic experience. So I had a participant who was forced by her insurance to see a physiotherapist that specialized in mental health and who was told that she should not listen to her needs, she should not take breaks, she should keep pushing herself. I had other people saying that people think that it's like something very soft and kind to stay in bed, when in reality it's a pretty traumatizing experience. I also link that to the fact that there is a lot of discrimination in education and in the workplace. As people, if you have a visible disability, it's harder to be hired. And then if you do get into the workplace, the unfortunate reality is that you are not fit to work. You won't be kind of like run out of your capacity, and a lot of people end up quitting. And it's really too bad, because I do believe that people who have chronic illness and people who have disabilities have like a unique perspective that makes them better practitioners. One of the reasons why I finally got better in the hospital and I was able to leave is because the new nurse assigned to me had a chronic illness herself, and she was able to listen to me and work with me to improve my capacity so I could go home on a stretcher, after 10 days. Another issue that a lot of participants have mentioned that I've also experienced is the idea that because long COVID does not look linear, we have good days and bad days, but if we don't perform our disability at the same level every day, we can actually face some pretty serious consequences. So a lot of participants have mentioned feeling surveilled or being surveilled. I had a participant who was a singer, and she sang at a concert for free for the first time in years, and her employer saw that she had sung and broke her employment relationship, son lien d'emploi. Because they said, if you can sing, you can work, you are faking it. I had another participant who said she was afraid of being on her balcony, taking a phone call with her sister, because she said, what if someone sees me on my computer and they think, oh, I could work from home, I'm going to lose my disability benefits. And it's something that I've experienced myself, where I'm like, oh, if a medical professional sees me walking, are they going to question the fact that I need a wheelchair? Because I know I can only do a few steps a day. But as soon as someone sees me standing, they think that I don't need anything. And it's something that really impacts your day-to-day life and your ability to enjoy the good days. There is also the issue of testing and assessments. They are very demanding, and they can trigger PEMs. The issue is that the PM is delayed. So let's say I do an assessment, the assessment harms me. Well, the person doing the assessment is rarely going to see me being harmed by it, because the PM is delayed. It happens the next day. So a lot of people with insurances especially are hurt by this, because the insurance is not going to see how the person was infected and will say, well, you passed the test, you are not eligible for the disability benefits that you're asking for. Another issue is that because of this fear, we feel incentivized to harm ourselves. So there's a lot of times where I've triggered PEMs to make sure I would get a service I needed. Like I triggered a PM to make sure I would get my adapted transport, because I was completely stuck at home and unable to move around the city. And I was really scared I would not get it. So a lot of the time when people acquire a new disability or new chronic illness, we talk about acceptance. One of the issues with long COVID is that it's very uncertain. We don't really know what's coming. So a sentiment I've heard over and over and again in the interviews is people who say, I would rather have cancer. So when people say that, they don't actually mean that they want cancer. What they mean is that they want a prognosis that they understand. They want a condition that is validated as real by people around them. And they want clear treatment steps. And when we talk about grief, the 5 stages of grief that we all know, they only apply to terminal illness. when we're talking about a loss that is ongoing and that will shape the rest of your life, what you need to do is to adapt to your new reality and to understand, make sense of that reality. And this is very difficult because with long COVID, not only is the present very inconsistent, but the future is also very uncertain. And I had a participant say that, like, to her, it's almost like a self-defense mechanism to be unable to picture the future because you don't know what can happen. I also believe that this feeling of powerlessness is shared by medical providers, and I think that it unfortunately contributes to a lot of the harm, because when we don't get better, we are often made to feel like it's our fault. So I had a participant say that she was doing her pacing correctly, she was doing everything right, but it was still not working. Like the idea of that energy envelope, and if you do everything right, you will be able to improve it. It didn't work for her. And she said like that she felt like it was her fault. If the treatment doesn't work, it's her fault, because if she was doing it correctly, it would work. I've also experienced being told directly that it was my fault. One day I was questioning a treatment that I thought would be harmful for me, and my doctor said, well, if you don't believe in it, it's not going to work. So once again, it's the limitation of medicine is being blamed on the patient instead of acknowledged with all the powerlessness that comes with it. So it is very difficult. It is a very unbearable reality, but it's a very important exercise for doctors to do that. And, you know, I have a lot of compassion, and I had a participant who was a doctor who has said that, like, you know, it is very hard. You want to help, you want to heal, and it's very difficult to reckon with the fact that you might not be able to. So I want to give you some quotes from medical professionals that I've interviewed who have long COVID. I had a physiotherapist who tried to rehabilitate herself using what she knew. So she thought she was deconditioned. And so she took herself to the woods every day, and she went walking and she went exercising, and every time she would get worse and worse and worse. And she was working with people who, you know, needed more rest and more pacing, like Parkinson's, etc. But for her, it never entered her mind that this could be happening to her. She thought she just had a virus. She didn't think it was a state or a condition. And so she realized that she couldn't just evaluate herself. She had to see other professionals. And finally, you know, and now pacing has been very successful for this person. I had an occupational therapist who, on the other hand, knew about pacing, but her limitation, and she was the only one who was able to work at the time of the interviews. And she attributes the fact that she was able to work to her ability to rehabilitate herself as an occupational therapist. But right now, she can only work and do nothing else. She can't cook, she can't clean, she can't spend time with her loved ones. And she said that if she could just take a year off and fully rehabilitate herself, she could go back to good quality of life. But she said that she does not have the finances to do this because there's no program that could support her for that time without burning all of her savings, which is a very scary prospect. I had a doctor who said that, yes, she was listened to more than the average patient, but the other side of that is that a lot of doctors basically put the burden of diagnosing herself on her, like saying, like, what treatment do you want? And she said that she was exhausted, she had brain fog, she was not able to do that kind of labor. But she also acknowledged that as a doctor, it's true that it looked very weird. She said, if I look at all my symptoms, they don't seem connected as a doctor. But as a patient, I know they are. And it kind of like gave her that perspective that if she didn't have long COVID, she might also have doubts about it. I had someone who worked in the administration of a SUS saying that she really believed in the healthcare system. She believed it would be here for her. And she was very disillusioned, realizing that unlike, for example, stroke care that is very organized, there is no organization for long COVID. There's no one showing up in your room and telling you what to do. And she realized that even with all her privilege of knowing the system, of being in the system, she felt like it was her against the healthcare system as a whole. So long COVID-like disabilities impacts your identity. I'm not going to linger on that a lot, but here are some quotes that I thought were very interesting about the fact that because long COVID prevents you from doing things, it means that not only do you feel impacted in your identity, if I can't do those things, who am I? But also it means that you cannot share things with your loved ones anymore. And like in the case of a mother, she can't even share the same space. She said that she felt very separated from her oldest daughter because unlike her youngest child, who was still young enough to stay in bed with her the whole day, her oldest child didn't want to be in bed all day. So they were literally in two different worlds, where her oldest daughter was growing up without her in a space that was outside of the bed. And that's I think it's a very interesting thing to say about like the loss of time, the loss of space, the loss of companionship that a lot of people are going through right now. Another reality of long COVID that makes it a bit distinct from other disabilities is that it's a very politicized syndrome. The reality is that a lot of people have friends and family who are COVID deniers or who minimize the impact of COVID. I had a participant whose husband won't even say that she has long COVID. She says, oh, whatever it is you have, which obviously impacts her self-esteem and her, like her feeling of safety in the relationship a lot. And a lot of people have very tense relationships with their family and friends because of this. It's also a reality that it's very difficult to avoid reinfection given the current social and political context. And it limits for people who are very worried about reinfection, which is the case of people who have gotten worse through reinfection, who are fearing becoming worse through reinfection. I had a participant whose ex-husband works in a hospital and refuses to wear a mask, and he brought COVID home to her, and she got COVID again, and she really went downhill, and she hasn't gone back anymore. So I just want to give you a few takeaways. It's not recommendations, it's just a few things that, first of all, yes, long COVID has an impact on our lives, and that impacts our mental health. But it's not the other way around. Long COVID is not a mental health issue. There is no cure. That's true, and that's very important to say that. But there are symptoms that can be treated, and people deserve to be offered options with full informed consent. It's true that when fatigue and pain don't react to treatment, it feels very powerless. It feels really horrible, both for the patient and for the provider. But if you reject that feeling, it can lead to blaming or dismissing the patients. Another reality is that long COVID traps people in that cycle of poverty and isolation. So when we talk about long COVID, we need to talk about disability rights as a whole. There needs to be options for people who are fully disabled and can't work anymore. That also means that if you work in an institution, you must be able to advocate against policies when those policies create harm, whenever necessary. You can't just hide behind the policy. And that is for, the next point is really for everyone, loved ones and etc. When you have someone who is going through this kind of stuff, their sense of self and belonging is really impacted. So you have to find a way to show up to their new world, even if it looks very small and scary, even if like the bed looks like a scary place to you, you have to find a way to make it work so you can maintain a connection with that person. You can reinvent the connection with the person. And finally, I think we talk a lot about curing and treating long COVID, but I think it's also important to think about prevention. Right. It's not inevitable that people get COVID. It's not inevitable that we get long COVID. I got COVID in January 2022, right after Quebec dropped, measures, and I don't think it's a coincidence. And I think it's important to say that this is preventable. There is still ways that we can fight, and we must resist. It is not fun to be in a pandemic, but I think that everyone who's making an effort right now to mask, to take precautions, to test, is really improving things for people who already have long COVID and people who might get it in the upcoming years. So yeah, thank you so much. I hope this was somewhat informative, and I will let Marie-Hélène take it away.
Yes, it was. It was amazing, Nathanael. Thank you so much. We'll get back after the presentation. So, Dr. Quinn, your turn if you're ready. Thank you.
Yeah, absolutely. Hello, bonjour. Je m'excuse, mais je parle seulement un petit peu de français, despite spending 4 years living at Prince Arthur and Clark when I did my bachelor's degree at McGill, and I love Montreal, and I'm going back in a few weeks with some friends who all went there together. But pardon my my lack of French. Really, really great to be here today, and thank you so much for inviting me to present. I'm truly honored to do it. What I'm hoping to do in 20 minutes is give you a little flavor of some of the evidence-informed recommendations and to point you all to where you can read about these and scrutinize them yourself, and hopefully can advocate for yourself or advocate for your patients to receive some of these treatments. And Nathaniel, what a wonderful presentation. It really resonated with me. And certainly one of the recommendations, which I won't be able to cover in this presentation, but is on the website, is a recommendation supporting the need for care coordinators like they do in other chronic health conditions for people with long COVID. And I think that CIUSS quote was very reflective of that need. I just wanted to highlight, I don't have any formal disclosures. I do receive salary support from our practice plan at Sinai Health and the University of Toronto. And all of my research in long COVID is funded by CIHR, either through the long COVID web or directly through our grants. So really just two simple objectives for today's talk. I wanted to spend a little bit of time helping people understand actually the process, the very thorough and comprehensive process that we go through when these single sentence recommendations come out. And so people understand that what goes into making these very important, I think, recommendations. And then I'll give you a couple of examples of the recommendations that have come up. And just sort of give you a sense of what those look like and help you understand those as well. So I think this crowd probably doesn't need to be reminded, but we're getting close to 1 billion recorded COVID-19 infections across the world, and that's those that are identified. I'm sure we're well past 1 billion, those many that are not identified. And in Canada, I think this number is probably even higher now, but the latest data from last year on sero prevalence studies looking at serum and antibodies to prove that people have had an infection, regardless of testing, that nearly 3/4 of all of us in Canada have been infected at least once with SARS-CoV-2, the virus that causes COVID-19. And, reflecting on Nathaniel's comments, people, especially some of our political leaders, would love to see COVID just disappear and they don't want to have to talk about it anymore. But it's not going away. So this is a graph from Public Health Ontario. We have a respiratory dashboard in Ontario. And so what you're seeing here on the x-axis is the number of cases, and on the y-axis time. And this is actually in hospitals. So this is because testing is largely gone, systematic testing. We don't know in the community how many people have COVID at any given time. And wastewater surveillance is sort of patchy now as funding dries up in various spots. But in hospitals, lots of hospitals still test. And so this gives you a somewhat reflection. The far left, you see 2022 from June into the winter season in the spring, a huge bulk of infections. Then last year, we saw a similar type of pattern in the fall and winter season. And over on the right here, up until this goes till October 30th, I think, is the most recent data. You can see we're on the upswing, and it's a wide curve right now. So we will find out in June just how big this is, but I suspect, we'll see lots more COVID in the coming months. So you can't get long COVID if you don't get COVID, and there's lots of COVID around. And so there's going to be lots of long COVID. So long COVID is not going away neither, as much as people want to imagine that it's not a real thing or it's not a problem anymore. 1 in 9 Canadian adults have had and experienced long COVID. And there are millions of adults and children living with long COVID in Canada at present, and they need our help. And that's where the work at CAN-PCC, so Canada Post-COVID, the Canadian Guidelines for Post-COVID Condition or Long COVID, we hope to help people and providers with the evidence to support care and treatment. I'm not going to go through all of the busy slides, and these slides will be on recorded, and I'm happy to share the slide deck if people want to look at it more in detail. But this is the jungle that is the multiple groups and boards that serve as part of the guideline development process. So Cochrane and McMaster is really a center of excellence for guideline development. And with a whole bunch of evidence synthesis teams who search the worldwide for the latest, greatest evidence, synthesize that, and then we put it through a series of checks and balances and expertise to get input on to make sure that the recommendations are reflecting the current evidence. So that goes from the individual teams that are responsible for different recommendations, an international advisory board, a central oversight group called the Guideline Development Group that reviews every recommendation and every bit of evidence that went into that, an equity oversight committee that makes sure that equity is always at the forefront of our thinking, a patient advisory panel, which we call the public member panel, that also gives us lived experience perspectives. But every team in our guideline teams also have multiple members with lived experience on that panel as well. So a very, very thorough and comprehensive process. One of the things that we use is called the grade rating system. And it's an approach that's very well developed that allows us to score the quality and the certainty of the evidence that we have before us, that allows us to arrive at a strength of a recommendation. And you'll see what that means when you see the recommendations in the coming slides. But effectively, this grade approach is really considered the gold standard in guideline development, and is not just used for long COVID, it's used for tons of different guidelines around the world, and really what clinicians rely on for high quality guidelines. And we use this framework within the guideline development committees that's called the evidence to decision framework. And what this does is it turns evidence, data, published studies, with a variety of other really important, we call them contextual domains, into a recommendation. So this schematic sort of summarizes that, where we start actually by identifying the important questions that need to be answered with the time and resources that we have. And again, that goes through a huge public consultation with key interest holders, including clinicians and patients and everybody effectively. Then we go through a process where we identify and prioritize those questions with a series of surveys. The evidence synthesis teams then search specifically for the evidence that would inform those questions, synthesize that, and then we have a series of meetings with the panels to go through and judge each of the evidence across different domains. Those are things like, do they help or do they harm? How much do people value the outcomes that we're looking at? Quality of life, fatigue and post-exertional malaise, all sorts of different types of outcomes. How much do those resources cost as far as an implementation? If we were to, prescribe everybody a drug, how much is that going to cost the publicly funded health system or privately funded health system? Equity is on there. Do people accept this intervention as something that they would be willing to receive? And how feasible is it? It's all very well to say we should be doing something, but if it's impossible to implement into our system, that's a really important thing to consider. This just shows you the 6 teams on our guideline committees that are addressing different topics, from prevention of post-COVID condition among people that do not have it, to recommendations around testing and diagnosis for making a diagnosis of post-COVID condition or investigating people with suspected post-COVID condition. I am the chair of the pharmacological and non-pharmacological interventions panel. There's a specific one on neurological and psychiatric topics because that was felt to be really important to have that as a separate panel to discuss. There's a panel that looks specifically on translating and making recommendations for pediatrics and adolescents. And then one that looks at the health systems. And that's where one of the recommendations, for example, on care coordinators in our healthcare system would be important. So I'm going to now take you through just a couple of example recommendations so you can see how these come to be. One of the questions that was prioritized was whether metformin, which is a diabetes medication, be used in people with post-COVID condition who are experiencing a new infection. So this is a really common problem now. We have lots of people with post-COVID condition and we're going through a wave of COVID. So should we be prescribing metformin to help people with post-COVID condition? And where did this come from? Why metformin? So there are some wet bench experiments, so in the lab, where you take cells of human lung tissue and other types of cell cultures, and they've looked at the dose, therapeutic doses, what we would give people in real practice of metformin. And that metformin shows that it actually inhibits and has activity against the virus that causes COVID. And it's thought to be through reducing inflammation and oxidative stress, which contributes to inflammation. And furthermore, in these studies, the earlier you give metformin, the larger the effects were seen. And that suggests an antiviral type mechanism by suppressing antiviral and viral associated inflammation. Now, this is just one domain. This is looking at the desirable effects, or what you would call the benefits of metformin, and the outcomes that we were able to find. And these are all pre-specified, prioritized outcomes. We look at the incidence of post-COVID conditions. So how many people are going to be developing post-COVID condition? We looked at quality of life, and unfortunately, all the studies don't always measure quality of life directly. So we use surrogate outcomes that reflect a measure of quality of life. And in this case, low oxygen levels or visits to the emergency room or hospital were felt to be indirect, but at least relevant surrogates. And what we do is we pool the evidence and then translate that into a number. So for people who take metformin at the time of acute infection, we find that there are 41 fewer cases per 1,000 of long COVID. And then we have some certainty around that estimate of 41, that it can go anywhere from 62 less all the way up to 11 less per 1,000. And similarly, you see the numbers there for the other two outcomes. If we look at the harms or the undesirable effects, metformin's been around for a long time. It's widely used. We're pretty certain of the undesirable effects that people experience with metformin. And so AEs are adverse events, and SAEs are serious adverse events. Adverse events are usually things like I got some stomach upset, maybe a bit nauseous, some diarrhea perhaps, which are common in some people with the use of metformin. Serious adverse events are things like I'm ending up in the hospital, you're dying, really, really significant factors associated with their use. And we really see trivial undesirable effects, which reflects what we know about real practice in metformin, that there really isn't a lot more adverse events with the medication. And so when we go through this domain by domain in the evidence to decision framework, we end up with this matrix, this table that's a summary table. And you say, yes, this is a priority problem because we have our process that defines it as a priority problem. There were small benefits seen as far as those outcomes we were able to measure. Trivial, undesirable effects from the adverse and serious adverse effects that we saw. There's very low certainty in that evidence, though, because the indirect measures, the risk of bias in some of these studies, the wideness of those that error around that estimate gives us very low certainty in that. And how do people value those different outcomes? Well, there's probably some or possibly some uncertainty or variability in how each person might value one outcome compared to another person. But overall, the balance of the effects, desirable and undesirable, probably favors metformin in the sense that there are small desirable effects and trivial or almost no undesirable effects. Metformin is relatively cheap. And if you have, in Ontario at least, if you're over 65, it's covered by the government, and a lot of private drug plans, if you're lucky to have that, is covered. So it's really not a very expensive drug. And we have a specific thresholds that we set for population level costs that give us these resources required. We have relative moderate certainty around those resources. There's no cost effectiveness studies that have been looked at for cost effectiveness in metformin and post-COVID conditions, so we don't have included studies. We think with metformin, there's probably no impact on equity because it's widely available and relatively cheap for most people would be able to afford it. And it's only for the time at which you have an infection with COVID, so it's actually short. So the cost is also not large, even if you don't have coverage for a short period of time. People are generally widely accepting of taking metformin, and it's very feasible to tomorrow just open up the doors if this was a recommendation for. So I just wanted to spend a few minutes just showing you how that whole table has worked for every single recommendation that we go through, but I won't do it each time for the sake of time. And so ultimately, we arrived at a recommendation that is for the use of metformin. And the wording is that in adults with post-COVID condition with a new COVID infection, we recommend using metformin. Now, this is what's called a conditional recommendation, and I'll tell you what that means on a separate slide. And we have very low certainty in that evidence. We also provide the dosing regimens that were used in the evidence that was available to inform this specific recommendation so that healthcare providers and prescribers and patients can advocate and know what to do, how much to take in for how long, if they wish to use it. The second question I wanted to show you was about antihistamines. These are drugs like Reactin or cetirizine, Benadryl, diphenhydramine, other types of antihistamines, often an allergic type medication that are used. And this is important because a lot of people, my patients and others, report symptoms that are consistent with this condition that's called mast cell activation syndrome. And effectively, that looks like an allergic reaction due to histamine release by these cells in our bodies called mast cells. And in some of the work I've done previously with experts, we made an expert consensus recommendation that based on really our clinical experience with people, that a trial of these medications would be reasonable if people had symptoms suggestive of this. But we actually we didn't have a process like this at that time to make that recommendation. And so I'll take you through what we did for this. And I think it's also really important just to help disseminate the knowledge and improve healthcare provider knowledge of what mast cell activation actually is, because most providers I've met actually have never heard of it before. And so I'm not going to walk through the diagnostic criteria, but just to say it's a very challenging condition to actually diagnose. But the symptoms are multi-organ, like the symptoms that people with long COVID experience. And a lot of them are in various types of allergic type reactions. And so, as I said, I'm not going to walk you through this here, but if you have 2 or more of these organ systems, and I always ask my patients with long COVID, do you have any of these? 1, 2, 3, 4, 5, 6, 7, 8. If they say yes, 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 then I say, you maybe have unrecognized mast cell activation syndrome, and maybe we should try helping you with that. So again, here's the summary of judgments that we used for this specific antihistamines table. And ultimately, we ended up splitting our recommendation that if people present with post-COVID condition and symptoms that are compatible with mast cells, you don't have to make a diagnosis, you don't have to do a blood test, but if they're reporting a variety of these types of symptoms, it's probably reasonable to try using antihistamines. And again, we give the specific ones that were used in the trials for people to help them. But it wouldn't make sense to give somebody who doesn't have those symptoms a trial of medications. So that's the separate recommendation that said, if you don't have those symptoms, don't trial a medication that would target those symptoms. And that, I think, is common sense, but we wanted to explicitly state that. The third recommendation I wanted to show you, which was a really important topic and is all over the media, was about low-dose naltrexone. And so we wanted to evaluate the evidence around that. And again, low-dose naltrexone, for those of you who are not familiar, it's a pain medicine, but it's also thought to have, it sort of modulates our immune system, and it might reduce inflammation and possibly neuroinflammation. And Marie-Hélène may be able to study that more with in her lab. Stabilizing the autonomic nervous system for dysautonomia. So there's lots of promise. And there is some evidence from the past in small studies that in people with ME/CFS that it works for them. Now, you have to remember that this process relies on published evidence. So if it's not published, anecdote is not evidence. And if it's not published, then there's no way to evaluate what's coming and emerging around the chat rooms and what patients will tell me that low-dose naltrexone used. And I think this is where some of the controversy comes in around this particular recommendation, and I'm happy to answer questions about it after. But ultimately, the evidence before us found no desirable effects and also no undesirable effects. And ultimately, these contextual factors, the costs of this drug, the ability to obtain it. And I think in Quebec, it's a bit easier, but in the Yukon territories, for example, there are no pharmacies that can even compound it. People have to fly to British Columbia to get it and then come back. So huge feasibility issues, and probably is going to reduce equity because those who can't travel somewhere, can't afford it, don't even have access to a compounding pharmacy to make it up for them, is reduced. So ultimately, our recommendation at present is against the use of low-dose naltrexone. And then again, that's a conditional recommendation with very low certainty. So I just wanted to help you understand. So those are the 3 recommendations I'm going to show you for today, but I'll show you where to find all of them in a minute. I did want you to help people understand what a conditional recommendation means, because most people just think that means don't use it, which is not true. So on this slide, it actually explains it at the different levels of the interest holders in our system. But for patients and for clinicians, most importantly, a conditional recommendation does not mean you have to do what we suggest. So if we say you shouldn't use low-dose naltrexone, a conditional recommendation means you can absolutely still use it. You just need to have a conversation between your patient or your physician prescriber to determine if it's right for you and you want to try it. So I think that's really important to understand, versus a strong recommendation, which is based on high certainty evidence, would say, don't do it. And there's many reasons why you shouldn't. But that's not the case for these recommendations. So I just wanted to highlight, if you want to learn more, and I posted a link in response to a question on the chat, specifically about dysautonomia treatment that was just released literally, I think, yesterday. But on the 1st of every month or thereabouts, there's a batch of new recommendations released, and this will go through into the new year. And you can find it at canpcc.ca. And all of these tables and all of the evidence that we considered, everything is on that recommendation. You just have to go through it if you're interested to scrutinize how we arrived at these recommendations. And I encourage you to do it to make sure we got it right. So in summary, there's lots of different evidence-informed recommendations that are published, and I've just given you a flavor of them today. I wanted to highlight the 5 that are available online now from pharmacological interventions, just so you are aware of them. So we recommended metformin to prevent post-COVID conditions in people with recurrent infection. We recommended the use of antihistamines to treat symptoms of mast cell activation syndrome. I can't remember what it is in French, my apologies. It starts with a P, I think. For dysautonomia, and this was to the question on the chat, there are several different medications that you can use to treat cardiac dysautonomia, depending on whether you have a racing heart as the predominant symptom or dizziness and low blood pressure. And we recommended against antiplatelets, things like aspirin, Plavix, for treatment of PCC, and we've recommended against the use of low-dose naltrexone. And I do want to highlight that there are, I think, 8 now Canadian-led clinical trials. I'm leading one of them on prevention of long-term outcomes, and there's a whole host of other really great people across the country. So new knowledge will come, and these recommendations should be updated in the future with that publication of that new knowledge, which will give us much better evidence on the treatment and care of people with post-COVID condition. So I hope in the relatively short time today that I've achieved the objectives to help you understand a little bit better the process which we go through, and to give you a flavor of some of those prevention and management recommendations, and pointing you to where you can find them on the website, and remembering that every month a new batch is coming out. Lots and lots of people just to thank. These are just a few of them, but it does really take a team to be able to do this kind of work. And I'm so grateful to work with really, really amazing and dedicated people, including our partners with lived experience. And if you have any questions, I'm happy to interact by email. There's my email address online. And I wanted to thank you all for your attention, and thank you again for inviting me to speak at this incredible day.
Thank you so much. I can tell you that the chat is very active, and there are a lot of positive comments about what has been presented today. First of all, Nathanael, I mean, there are a lot of people thanking you for your personal experience, and I can see that the narrative is very resonating with a lot of people. So a lot of acknowledgement of this really great presentation.